Hi everyone, welcome to Research MD, and this is Dr. Pramil, Program Director, Internal Medicine Residency Program. We're going to continue our high yield in-service training examination questions for the Internal Medicine Residency Program. Very, very important. A lot of people don't understand the consequences of failing the in-service training exam. It have a lot of implications, which we'll talk further. So the topic today we're going to talk about is acute gout management. Okay, so the first question is, 55-year-old man present with acute onset of severe pain, redness, swelling in the right big toe. He has history of gout and takes hydrochlorothiazide. Joint aspiration showed needle-shaped crystals with a negative birefringence under polarized light. Which is the following is the most appropriate treatment? We got 4 options: allopurinol, prednisone, colchicine, and probenecid. So the answer again, number 1 is always colchicine, okay? And then you have to start within 24 to 48 hours. The thing about colchicine also, you can give, don't give colchicine with his stage 4 kidney disease. Otherwise, you can do the dose adjustment in stage 1, 2, and stage 3, okay? Now, the pathophysiology of the gout is also important. Sometimes they can put a picture of the ultrasound. It's called double contour sign, okay? So that's what this picture, next slide, that when you see a picture like that, always your answer should be gout. Double contour sign, remember that, okay? Now, the treatment again, again, NSAID, because of the NSAID can cause a lot of stomach problems, kidney, and all of that, right? And then the colchicine should be the first one. Caution. The word is caution in renal impairment. Corticosteroid, the next step is always try prednisone if they cannot tolerate NSAID or colchicine. And the other chronic management is the uric acid lowering therapy. You have to check the uric acid, and you can have allopurinol, febuxostat, proglioticase. And the lifestyle modification, remember, corn syrup, high fructose corn syrup. You have to be very, very careful. That's another board question. We'll talk about it later. So let's look at the number 2 question. A 60-year-old woman come with a recurrent gout, present with the follow-up. Uric acid level is high at 9, has had 3 attacks in the past year. She is currently symptomatic. Which of the following is the management? Begin allopurinol, prescribe colchicine prophylaxis, avoid purine-rich food, switch to febuxostat. So the answer is begin allopurinol, because uric acid lowering therapy, number 1 drug. The first drug is allopurinol. But you have to be careful about allopurinol because it can cause allergic reaction and people can die. Just be careful. Okay, question number 3. A 55-year-old man present with a sudden onset of severe pain, redness, swelling, right grade toe for the 12 hours, history of hypertension, chronic kidney disease, type 2 diabetes, examination of warm, erythema, tenderness of the first MCP joint, white blood cell count, synovial fluid they did, white blood cell count 20,000, needle-shaped negative birefringent crystals. Which of the following is the most appropriate treatment for this patient? You got indomethacin, colchicine, intra-articular corticosteroid, allopurinol. Okay, so in this case, patient had chronic kidney disease and a lot of other complications. Intra-articular corticosteroid is the right action because patient has acute gout, chronic kidney disease. And when you have NSAID and colchicine, be careful about the chronic kidney disease, and then intra-articular corticosteroid is the best option here. Okay, question number 4. A 60-year-old male with a 15-year history of gout, person with a recurrent attack. He reports experiencing more than 3 gout flares in the past, and he got a tophi in the finger. He has been treated with allopurinol at the maximum tolerated dose and febuxostat sequentially, but continues to have uric acid level above target, recurrent flare. So which of the following is the most appropriate next step in the management? Again, increase the dose of febuxostat, add low dose of colchicine prophylaxis, initiate proglioticase, perform surgical excision of tophi, start probenecid. The key is how to use proglioticase. This is the one they convert uric acid to allantoin, which is easily excretable. So when to use when there is a visible big tophi sitting there, pick proglioticase. There is a erosion, damage to the joint and all that, I would give proglioticase, okay? That's the key. Now, take away acute gout, NSAID, colchicine, worry about renal function, and prednisone, intra-articular corticosteroid, the like acute management, the chronic management. You need to know about allopurinol, hypersensitivity reaction, febuxostat, xanthine oxidase inhibitor, and then you have to know about pergloticase. If there's a big tophi and a chronic gout is not getting better, I think 3 flares per in 24 hours or something, you need to use pergloticase. Okay, remember pergloticase, febuxostat. People usually forget to know those 2 drugs also very important now these days. Thank you so much for watching. Please continue to watch. So we'll make more presentation like this, so you can score extremely high in your in-service training exams. So you will shine as an internal medicine resident. Thank you so much for watching. God bless.